Welcome back. President Obama is pressing Congress to overhaul the healthcare system, but major concerns remain. Katherine Baker is professor of health economics at the Harvard School of Public Health. She joins us now from Boston with her assessment. Professor Baker, welcome to Bloomberg News.
Thank you for having me.
You saw the president's press conference last night, as we mentioned, dominated by the discussion of health care reform. What did he say that impressed you? What did he say that left you with some concerns?
I really applaud the emphasis on covering the uninsured and at the same time getting cost growth under control. Cost growth obviously makes it harder for people to afford insurance, but it makes it harder for the people who have insurance now to continue to afford it, and also threatens to keep wages from growing as quickly as they would otherwise.
Well, where can we publicly subsidize? I think that's one of the keys that's not getting a lot of play here.
One of the challenges in figuring out how to design public subsidies is figuring out where to draw the line on what to cover and how to finance that coverage. I think we're all in favor of cutting out spending on health care that doesn't actually produce health, and there's evidence that there's a fair amount of that. But pretty soon we're going to get to some much tougher decisions about cutting spending on care that might improve health, but not by enough to warrant the public expenditure.
Professor Baker, you talk about some myths and misconceptions that are out there, and that's undermining the development of a productive conversation on health care reform efforts. One myth I think you kind of explore is about extending health care to the uninsured, that would be money well spent. Would it be not, or that's not the case?
I absolutely believe that it would be money well spent, but it doesn't pay for itself. I think we'd all like to think that if you cover the uninsured, the improvement in the quality of the care that they would get and the reduction in emergency department usage instead of primary care would finance that coverage, and I don't think that it would. So it would be money well spent because it would produce a lot of health for those people, and that's a really important thing to do, but it wouldn't pay for itself, unfortunately.
What about the arguments out there that preventive care is much better than waiting until you've got to go to the emergency room? I mean, what about that argument? Are there any myths out there?
I think that's absolutely true, that preventive care is, again, money well spent in terms of improving health, but most preventive care also doesn't pay for itself. A lot of people who get preventive care then live longer and healthier lives and consume more health care, and that's a good thing, but it's not free.
Professor Baker, as the president mentioned last night, a reporter had asked him, basically that the argument goes, why don't people in this country have the same type of health care as the president of the United States does, or as their representatives in Congress and in the Senate do? This has been something that's been going on, as the president's been pointing out, since Harry Truman has been president, trying to deal with this. How can this get done now, whereas it failed before? What are the advantages now?
As the president pointed out, the current system is unsustainable, and the status quo is not something that I think anyone would vote for. With costs rising so rapidly, both for public insurance programs like Medicare, Medicaid, that puts a strain on state budgets as well as federal budgets, and private insurance that's increasingly unaffordable, I think we've all come to realize that leaving the current system as is not a viable option.
But as you know, there's that $1 trillion figure that's been bandied about. Even in these economic times, that's a staggering amount of money. So the question then becomes, can the country afford it? Or is the other side of the question, can the country not afford to do this at this time?
That's where those tough choices that I mentioned come in. We can afford to ensure that everyone has access to a reasonable package of life-saving care. What we can't afford to do is subsidize an unlimited amount of care for everyone. So we need to make some tough choices about how to allocate our scarce resources so that everyone has basic care while not continuing to subsidize more and more and more care with lower and lower and lower health value for everyone.
Kate, does that lead to rationing then? You essentially put a price on everything, whether or not this operation makes sense to do. I mean, will that lead to rationing?
Rationing is a very unpopular word, I think for good reason, but what we have to realize is that the miracle of modern medicine means that there's a virtually unlimited amount of care that we could deliver, and we can't afford that as a nation. That's more than 100% of GDP. So when we think about how to allocate scarce resources, there has to be some mechanism, either by individuals and their physicians deciding whether the care is worth the resource cost.
What about the government role in rationing? Just got a few seconds here, 5.
There has to be some government role in figuring out what public insurance programs are going to cover and what we can't afford for them to cover, and those are tough choices.
Our thanks to Katherine Baker, professor of health economics at Harvard School of Public Health.